Welcome to this explainer. Today, we're going to look at the critical life or death interaction between pneumonia pathogens and pharmacology. And honestly, we're treating it exactly like what it is, a strategic battlefield. We're not just talking about bugs and drugs here. We're looking at the tactical deployment of medical artillery to save lung tissue and ultimately save lives. Let's get right into it. So, you might be wondering, how do doctors actually match the exact right drug to a deadly lung infection? It's a massive, high-stakes matching game. If you choose a weapon that's way too weak, the pathogen just overruns the host. But if you choose one that's unnecessarily broad, you're contributing to global antibiotic resistance. So how on earth is this decision made? Here's our clinical roadmap for the explainer. First, categorizing pneumonia types. Second, decoding the drug classes. Third, first-line therapies and dosages. And finally, resistance and alternative treatments. Section 1, categorizing pneumonia types, knowing the enemy. Okay, so the absolute crucial point to start with is timing. 48 hours. Infections acquired before a patient has been in the hospital for 48 hours are considered community acquired. But the literal second we cross that 48-hour threshold, boom, it becomes hospital-acquired pneumonia. And this isn't just some administrative billing code. It completely changes our suspected pathogens. Why? Because the hospital environment breeds entirely different, much tougher bacteria. The physical environment literally dictates our likely enemy here. In community-acquired pneumonia, or CAP, the most common bacterial pathogen is Streptococcus pneumonia. But shift to the hospital setting, HAP, and suddenly we're facing nasty gram-negative organisms like Pseudomonas or drug-resistant MRSA. And if a patient is intubated, well, within 48 to 72 hours, they are at a super high risk for ventilator-associated pneumonia. Oh, and even if someone just came from a nursing home, they fall into the healthcare-associated category. That means we absolutely have to suspect those tougher, hospital-like bugs from minute one. But check this out. Even within community-acquired infections, the enemy wears totally different uniforms. Contrasting typical alveolar consolidation with atypical interstitial presentations shows us exactly why different drug strategies are required. Typical pneumonia hits the alveoli really hard. You'll see clear lobar consolidation on an X-ray and a massive spike in white blood cells. But atypical pneumonia, caused by elusive bugs like Legionella or Mycoplasma, well, that hides out in the interstitial spaces. Patients might actually have minimal physical signs when you listen with a stethoscope, but their X-ray, it shows bilateral patchy infiltrates. It's a completely different battlefield, requiring entirely different tactics. Section 2, decoding the drug classes, opening the armory. Now that we know the enemy, let's open the armory. These drug classes represent our main tactical deployments. We range from broad-spectrum beta-lactams to highly targeted glycopeptides. Think of the beta-lactams as your infantry, reliable and widely used. Macrolides and fluoroquinolones, they're your specialized units, able to strike specific targets like those atypical bacteria we just talked about. And your aminoglycosides and glycopeptides, that is your heavy artillery, reserved for the most heavily fortified, resistant gram-negative and gram-positive threats. Let's look closer at beta-lactams. They are our definitive first line of defense. They're actually the most widely used antimicrobials in human medicine, and they work by literally destroying the bacterial cell wall. However, and this is a big however, we must always be wary of bacterial intelligence. Pathogens have evolved these enzymes called beta-lactamases that literally chew up our drugs. That is exactly why we often have to combine them with inhibitors or escalate to stronger classes like carbapenems. Section 3, first-line therapies and dosages, tactical deployment. Okay, looking at the clinical algorithm for home-managed community-acquired pneumonia, when we're fighting standard threats like Streptococcus pneumonia, we rely heavily on aminopenicillins, like amoxicillin, as our primary strike. It's effective, it's targeted, and it's oral, making it absolutely perfect for outpatient victories. But what happens when CAP becomes severe and the patient is in respiratory distress? Well, the tactical playbook changes immediately. You literally cannot wait around for lab cultures while a patient's lungs are failing. You need a rapid combination of intravenous therapies to stabilize them right now. The guidelines mandate hitting the infection from two different angles. A strong beta-lactam like IV coamoxiclav or ceftriaxone, combined with a macrolide. This ensures we're covering both typical and atypical bacterial threats simultaneously. No gaps in the defense. Now, the crucial point here is absolute precision. In medicine, a weapon is only as good as its dosing schedule. This table breaks down the exact frontline dosages. For amoxicillin, it's zero point 0.5 grams 3 times a day, taken orally. But notice how azithromycin is given just once a day? That's thanks to its long half-life in the tissues. You have to maintain the exact right concentration of the drug in the blood to keep the bacteria suppressed. If you don't, they regroup, mutate, and come back stronger. Shifting back to the hospital battlefield. For hospital-acquired and ventilator-associated pneumonia, where there are no known risk factors for multi-drug-resistant pathogens, we deploy targeted IV therapies like ceftriaxone or fluoroquinolones like levofloxacin. The main goal here? Hit the hospital-acquired strains incredibly hard before they can establish any sort of foothold in already compromised lungs. Section 4. Resistance and alternate treatments. When the plan fails. So here we see a total shift in strategy. Atypical pneumonias render standard penicillins virtually useless. Why is that? Because bugs like Mycoplasma don't even have a standard cell wall for the penicillin to attack. It's literally like trying to breach a fortress that doesn't even have walls. This forces us to pivot to drugs that work inside the bacterial cell, interrupting their protein synthesis. That's exactly why we shift gears to macrolides like clarithromycin or tetracyclines like doxycycline. Now, when we face the absolute worst-case scenarios, I'm talking multi-drug-resistant pathogens in the ICU, a single drug will almost never win the fight. We must aggressively combine forces. This algorithm dictates pairing an anti-pseudomonal agent like cefepime or meropenem with a fluoroquinolone or an aminoglycoside. Plus, we often have to add linezolid or vancomycin if MRSA is even suspected. It is a highly coordinated, multi-pronged chemical assault. This step-up approach perfectly frames dosage shifts and powerful drug additions as targeted clinical decisions based on emerging threats. You start with your strong baseline, a third-generation cephalosporin. But wait, what if the patient is immunocompromised and we suspect listeria? Well, cephalosporins don't work on listeria at all. So step 2, we immediately add IV ampicillin. What if we're in a region with highly resistant Streptococcus pneumonia? Step 3, we bring in vancomycin. It's an incredibly dynamic, adaptable combat strategy. When fighting heavily resistant strains, we bring in the heavy artillery. But guys, these weapons are dangerous if mishandled. Notice the extreme precision required here. Gentamicin is dosed strictly by weight, 5 to 7 milligrams per kilogram, just to prevent kidney damage and hearing loss. Vancomycin requires rigorous therapeutic drug monitoring to ensure we're hitting the bacteria without destroying the patient's renal function. And meropenem? That's infused slowly over 30 minutes. We rely on these incredibly precise protocols to ensure victory without causing extreme toxicity to the host. As we wrap up this explainer, I want to leave you with a profound thought about this ongoing, high-stakes arms race between adaptable pathogens and our medical innovations. We've mapped the battleground, we've decoded the armory, and we've analyzed the tactical dosing. But bacteria are ancient, and they are incredibly fast learners. Every single time we deploy our heavy artillery, they are mutating to build better defenses. So I ask you, as the bugs get smarter, are we innovating our pharmacological arsenal fast enough to outpace the evolution of antibiotic resistance? Thanks for joining me today, and keep learning.